Okay, shall we start now? Good afternoon, everybody. Welcome to this step-in program for the structured training and education program for nurses. Today's topic is evaluation and management of oliguria. This is mainly for a nurse's perspective. So today, let me introduce our speaker for the day, Dr. Sumona Paul. She is a senior consultant, and she had her training in Apollo Hospitals, Jubilee Hills in IDCCM and IFCCM, and she has been a senior intensivist in this field in various hospitals in Hyderabad, like Sunshine Apollo Hospitals. Currently, she is a senior consultant in one of the tertiary care hospitals in Orissa, in Rourkela, and she is heading the neuro intensive care with a completely dedicated neurotrauma team. I hope she will do justice to the program, and we will have a structured program, and whenever there are some queries, you can please put it into the chat box so that we can discuss it. So over to Dr. Sumona. Thank you.
Good afternoon, everybody. I'll be starting off my presentation. And today we are going to talk about evaluation and management of oliguria.
Dr. Sumona, please unmute yourself.
Yeah, sorry, I was not able to share. The main objectives of this presentation will be identifying the etiology of oliguria, describe the appropriate evaluation steps for assessing oliguria, screening and identifying the patient who are at risk for developing oliguria and subsequently AKI, summarize the management option for oliguria, and implement preventive strategies. I'm having some issues in going to the next slide. Sorry, there were some issues with the slide. Hopefully, we don't have the same problem. Now going to the first slide.
This has already been done. You can shift to the next one.
Yeah. We start off with the question. This is about a 45-year-old hypertensive male victim of the road traffic accident, who actually in the accident had injury to the long bone, fracture of both upper limb and the lower limb. And he was on angiotensin receptor blockers from before. He was taken up for open reduction and internal fixation. The following day, he suffered from a massive pulmonary embolism requiring thrombolysis. He started becoming oliguric. He was also having hypertension, and on investigation, it was discovered that he had developed retroperitoneal hemorrhage as a complication of anticoagulants. He required surgical drainage. Now, after returning from the operation theater back to the ICU, he remained oliguric. Now, the question is, how can we manage this patient going towards renal injury? So we'll discuss this case in the timeline. To start off, the definition of oliguria. Oliguria is when the urine output is less than 400 ml per day, or it is less than 0.5 ml per kg urine output for at least 2 hours. Now, this is not a clinical diagnosis. It is actually an early sign of an underlying disorder. So if it is not treated, definitely it's going to lead to AKI and hence all its sequelae. So it can lead to acidosis, hyperkalemia, and the other problems associated with AKI. The etiologic factors, depending upon the pathophysiology, it entails pre-renal causes, the renal causes, and the post-renal. This is something we are going to discuss today. To start off with the anatomy, it is just to brushing up your anatomy. I'm sure all of you all must be having some faint ideas. Over here, what we see, this is the glomerulus. And this is a tuft of the capillaries with an efferent arterioles, the efferent arterioles. And here, if you can see, we have got the glomerulus in the cortical part of the kidney, and this is the medullary part of the kidney. And from the glomerulus, we have got the proximal convoluted tubule, which goes down into the medulla as a loop of Henle. It comes out, and then you have got the distal convoluted tubule. And this ends into the collecting duct. So this is the basic functional unit of the kidney. And in a kidney, there is almost more than 1 million nephrons. And here I've got a picture of the distal convoluted tubule, which has got this green marked cells. These are the macula densa. These are the cells which actually are part of the juxtaglomerular apparatus and are responsible for secretion of the renin. This is for your knowledge. I think so with this, you will be able to understand the concept of oliguria better. So when we are talking of the causes of oliguria, we were talking of pre-renal, the renal part of it, and the post-renal. So when we say pre-renal, that is everything happening before the kidney enters into the scene. So it can also include the cardiac issues. It can have some problem with the arteries, the renal artery, and the renal part is the kidney per se. So any kind of pathology involving the kidney. The post-renal is beyond the kidney. So it includes the ureter, the bladder, and the urethra. So what are the pre-renal causes? The commonest cause for the pre-renal AKI is hypovolemia. So we should be very sensitive. Suppose there is a decreased effective blood volume. It can be because of fluid loss. It can be because of decrease in fluid intake. Bleeding, GI blood loss like diarrhea, vomiting, or nasogastric suctioning, the renal losses. That can be because of diuretics and also glycosuria. We all know in diabetic patient, because of glycosuria, there is increase in urination. So this also entails to hypovolemia. Then the other diseases which can lead to third spacing of the fluids like ascites, pleural effusion, trauma where there is bleed or hemorrhage leading to hypovolemia, surgery, burns, sepsis. Sepsis, we all know that there is a effective central hypovolemia, anaphylaxis, hepatic failure, and also due to anesthetic agents. The other cause for the prerenal AKI can be pump failure. This is when the heart is involved. So if there is a myocardial infarction or there is cardiac tamponade, congestive heart failure, these all will lead to pump failure, and hence the amount of blood coming out of the heart will be decreased, and that leads to the hypoperfusion of the kidney. And the similar thing for pulmonary embolism. The vascular causes, it can be because of the renal artery thrombosis, occlusion, or there is any kind of venous occlusion. So here is a kind of a diagrammatic presentation where you can see a cork-like obstruction of the renal artery. And that can be because of some thrombus or emboli, and that decreases the blood supply to the kidney. There's another interesting thing. This is the renin-angiotensin-aldosterone system. I'm sure you all are aware of it, that the kidney is managed by autoregulation. So any blood pressure between 60 to 160 can be autoregulated. And how it is autoregulated? We just now saw that the juxtaglomerular apparatus, that is where the renin is getting secreted. So renin converts the angiotensinogen to angiotensin 1. The angiotensin converting enzyme, it converts angiotensin 1 to angiotensin 2. And this angiotensin 2, it stimulates the sympathetic activity, the tubular absorption of sodium and water. It also stimulates the aldosterone secretion. This aldosterone is the one which actually stimulates the distal tubule for absorption of water. And all these things in the end lands up increasing in blood pressure. So here we see there's another picture of an atrial vasoconstriction. Obviously, this also leads to increase in blood pressure. And angiotensin 2 also stimulates the ADH secretion. Now, this is from the pituitary. ADH, it stimulates the collecting tubule for more of water absorption. So this renin-angiotensin-aldosterone system, it tries to maintain some BP so that the perfusion of the kidney is not hampered. So if there is hypovolemia or there is any pain or nausea sensation, these can stimulate the sympathetic activity. And this can also stimulate the antidiuretic hormone or the renin-angiotensin system. Now, all of these, this is actually leads to increase in the blood pressure and hence it's kind of amelioration of oliguria. And the other way, pathophysiologically, we know if there's renal hypoperfusion, if there's sepsis or nephrotoxin, cast nephropathy, all these things, if they are not checked, if they lead to oliguria and later on can lead to AKI.
Here is a question for all the students, those who are attending this. So this is about a 67-year-old female in congestive heart failure. He was admitted to the hospital ICU. Incidence data indicate that hospitalized elderly patients, they are susceptible to developing acute kidney injury. And the percentage of all hospitalized patients who may develop AKI is, which of the following is the correct answer? So the first one is A is 5 to 8, B is 8 to 12, C is 13 to 18, and D is 22 to 25. So those who want can please write in the chat box. Can somebody make a fair guess about it? You have a few seconds. Please try to make a guess. There is no hard and fast rule that if you don't fail to give the correct. 8 to 12, fine. Okay, somebody else can try also. So the answer is C, it is 13 to 18. So Sagarika, please don't feel bad that you have answered it in a wrong manner. No. See, the answer here it is 13 to 18 is a significant amount of hospitalized patients in the hospital. They get AKI. The incidence is higher for those patients who are getting admitted to ICU. So according to one estimate, it is said that 1 in 5 adults and 1 in 3 children experience AKI during hospitalization. The idea of putting this question in this particular session in the midway was to highlight to all of you the importance of getting AKI, of understanding oliguria, that which can ultimately lead to acute kidney injury. So it is much common than you all think, and it is much more dangerous, and it directly has AKI directly has got a effect on mortality of the patient and increased day of hospitalization and increased incidence of need for renal replacement therapy in the patients. So yes, it is a dangerous thing and it is much more common than we all think to be. Thank you. Dr. Sumona, please continue.
Thank you. This is for the renal causes. So renal causes means something involving the kidneys per se. So what are the parts of it? The renal for the renal causes, it can include the arteries, the glomerulus, the tubules, and also the interstitium. So there can be direct damage to the glomerulus, causing glomerulonephritis. And sometimes we are aware of it that malignant hypertension, it causes a compromise in the renal microvascular blood flow. And vasculitis, interstitial nephritis, all these are also renal causes. There's another thing, the acute tubular necrosis. Here, the tubules are involved. And the majority of the causes for the renal causes is the ischemia. Ischemia is almost 50% and the nephrotoxins are almost 30%, which together leads to AKI. So drugs which we are aware of, they can be gentamicin, the amphotericin B, the toxins like mercury and the radiographic contrast agent. These are very important in causing AKI, and we should be very careful whenever we are prescribing radiographic contrast to the patients. So the glomerular damages causes only 5% of the patient, and it's very similar to the damage mechanism in the renal vasculature, because the glomerulus itself is like a capillary system with this efferent and the efferent arterioles. The tubular damage, as I was telling, 50% is as a result of ischemia and 35% is because of the toxins. The interstitial damage, the acute interstitial nephritis, there's also a term, you must have heard of it. And this is usually an hypersensitivity, delayed hypersensitivity immune reaction. And it can be caused by infection, caused by drugs, and also autoimmune disease or idiopathic causes. Now we come to the post-renal causes. Less than 5% of all the etiological factors are because of the post-renal causes. And what is the commonest reason? It is because of obstruction. So the obstruction can be in the upper urinary tract or it can be of the lower urinary tract. The upper urinary tract obstruction is usually due to the ureteral obstruction. So it can be a calculi in the uterus, the ureteral part of the kidney, or it can be because of pelvic malignancy. Now, if there's any malignancy involving the uterus or to the ovarian, it can cause compression on it. Or it can also be the ureteric injury during any retroperitoneal surgery. Lower urinary tract, it is the commonest is the bladder outlet obstruction. It can be because of the benign hypertrophy of prostate. It can be the tumor of the prostate. Sometimes even improper placement of the catheter, urethral catheter, can cause obstruction. So this obstruction can be because of it can be placed in a wrong place, or there can be some kind of obstruction to it. So suppose a catheterized patient doesn't have any urine. So first thing we should think of the catheter obstruction. So we should give a bladder wash, or you can remove the catheter and see if there is any urine formation. The other obstruction, which can be in the which we see now, it can be the obstruction actually increases the pressure in the upstream. That is, there's expansion of the renal pelvis, the calyceal system, and the ureter, and this is known as hydronephrosis. So pathophysiology, if I summarize over here, oliguria is actually secondary to pre-renal causes, which resolves with the restoration of the normal renal pathology and decrease the renal blood flow. There is neurohormonal pathways are activated. This in turn increases the renin-angiotensin pathway, and this all leads to increase in the renal blood flow. The increased water and salt resorption to maintain an adequate glomerular filtration and the renal blood flow, otherwise reduction in GFR or the renal blood flow. The renal causes are due to tubular damage. It can be because of the kidney loses its normal function, that is production of urine while excreting the waste metabolites. The post-renal causes are urine production is normal, but there's an obstruction in the urinary tract leading to oliguria. So here there is a approach to oliguria. We will be starting with the history and physical examination. History is very important. So we should be taking the history. Was there any history of fluid loss, like the patient had diarrhea, vomiting, or was there any history of burns? The patient may have pancreatitis. There will be third spacing loss, or there's any toxin with drug history of exposure to the NSAIDs or radiographic contrast exposure. Sometimes the patient can be complaining of fever, rashes, arthralgia. It can be because of infection. It can be because of autoimmune reason also. Or you can ask about the urinary symptoms, if there are any change in the color or the volume. The recent surgery or the anesthesia can also cause effective hypovolemia, which can cause renal damage. If there's any urethral injury or any history of pelvic malignancy. A patient who has got any renal problem usually will be complaining of nausea, vomiting. The patient with uremia will be having malaise, fatigue. And there is a complaint of flank pain. It can be bilateral or unilateral. So if it is calculi, it can be uretary calculi, unilateral or bilateral. And then the patient can also complain of headache. Suppose a patient has got malignant hypertension. On examination, we should first try to rule out shock. Is there any hypovolemia, hypotension? And the other thing we should keep in mind, suppose there is an abdominal compartment syndrome. Now, this abdominal distension can also lead to compression of the renal vasculature, leading to decrease in urine formation due to hypoperfusion. Then if there is any gel-like edema, the pulmonary edema, if there's hypotension or any ECG abnormalities, which we can see in patient having electrolyte abnormalities like hyperkalemia. Investigation-wise, we should always ask for the electrolytes, that is sodium, potassium, creatinine, the blood urea nitrogen. Other electrolytes are calcium, magnesium, phosphorus, creatinine phosphokinase. Suppose a patient has got a history of trauma. So rhabdomyolysis, if you are suspecting, there will be increase in creatine phosphokinase. And hemolysis, that will lead to elevation of unconjugated bilirubin and also lactate dehydrogenase. If necessary, if the patient has got some glomerular problem like the nephritis, glomerular nephritis, we can ask for anti-nuclear antibodies, the ANA, neutrophil cytoplasmic antibody, complement level, or anti-glomerular basement antibodies. That is when we're suspecting Good-Pasteur syndrome. Or it can be MPGN or post-immune glomerulonephritis. The other thing we can keep in mind, suppose a patient has got hypercalcemia or hyperglobulinemia, we can suspect paraproteinemia, and we can ask for a routine electrophoresis, both of serum and urine. The other urine investigation, which is the urinary cast and the sediments. So if there's a pre-renal problem, the one which is affecting the kidney before it actually involves the kidney per se. And in those kind of cases, the sediments are usually very bland. It can have hyaline cast. So we can think of arterial thrombus, embolism, and also the other diseases which will be affecting the pre-renal part. The renal disease or the intrinsic renal disease, in these cases, usually there will be the RBC and dysmorphic RBC. This is because for glomerular hematuria, or you will be having the RBC cast. So the glomerulonephritis, vasculitis, the thrombotic microangiopathy, all these will be having the RBC involvement. For interstitial nephritis, there will be eosinophil or the eosinophilic cast. WBC cast will be there for pyelonephritis or any other infection. It can be because of malignant etiology and also for interstitial nephritis. For acute tubular damage, there will be muddy brown epithelial cast. Dipstick tests can also help in investigation and arriving at a diagnosis. It can be detecting proteinuria, hematuria, glycosuria, when there is urobilinogen or hemoglobin positive. Suppose hemoglobin is positive in absence of RBCs. So we can think of myoglobinuria or there is hemolysis. In infective causes like pyelonephritis, we can have a positive nitrite test. And crystalluria involving the calcium oxalate, ethylene glycol intoxication can cause this. Urinary finding for certain etiology. This is a very interesting thing. So suppose urine analysis, we find we are suspecting pyelonephritis. So there will be presence of nitrites, as I had told earlier, and leukocyte esterases. And for tubular damage, the protein will be in the milder form. For those involving the tubules, tubular damage, pyelonephritis, glomerulonephritis, it can also be moderate, and very large loss of protein can be seen in nephrotic syndrome and other glomerulonephritis. In presence of hemoglobin in the urine analysis, it can be of stones, the renal stones, or it can be tumor. It can also be because of renal infarct or glomerulonephritis. Suppose it is myoglobin. That means there is rhabdomyolysis, which is leading to tubular necrosis. Urobilinogen also we can see if there is hemolysis associated tubular necrosis. And urinary sediments, if we see microorganism, obviously we'll be suspecting pyelonephritis. This is the urinary biochemistry. This is a very important table. This actually differentiates between the pre-renal and the renal causes. And there are certain things which we should be knowing well. The urine osmolality, suppose it is pre-renal, it is maintained well above 500 milliosmol. But if it involves the renal, that means the capacity of the kidney to make the urine, it decreases the water, it increases the water content and it increases the osmolality, decreases the osmolality. So the osmolality in the renal causes will be less than 350 milliosmoles. In the same way, the pre-renal, the urine sodium will be less than 10 MEQ, whereas in the renal causes, it will be more than 20 MEQ. So again, there is loss of the sodium because of the dysfunction of the tubules. The ratio between urine and the plasma osmolality. In the pre-renal causes, it will be more than 1.5, and the renal causes, it will be less than 1.2. The plasma Bunn and the creat ratio in the pre-renal causes, it will be more than 20. So this actually gives an idea that the patient is hypovolemic and requires fluid administration. The specific gravity will be more for the pre-renal, and it will be almost equal to 1.010 for the renal causes. The fractional excretion of the sodium %, it will be less than 1 in pre-renal and more than 1 in the renal causes. The urine and the plasma creatinine ratio, it is more than 40 for the pre-renal and less than 20 in the renal causes. So these are very important to differentiate between pre-renal and the renal causes. And many a time in the questions, we are given all these numbers, so we should be aware of this. This is a little bit of explanation of the fractional excretion of the sodium. This is actually a better diagnostic parameter to differentiate between the different causes of AKI. And you must have also heard there is the fractional excretion of urea is also taken. So for the value of FeNA, it is less than 1 and more than 1. For urea, it is usually if it is less than 35 and more than 50. So this is the way you can differentiate between the pre-renal and renal. A low urinary sodium, less than 20 milliequivalent per liter, and a low, the fractional excretion of sodium, less than 1% in a patient actually indicates the patient is hypovolumic, and the oliguria actually suggests that there is stimulation for sodium retentive mechanism in the kidney and the tubal function is intact. So this is a pre-renal azotemia. Whenever there is inability of the kidney to concentrate urine, that means there is loss of all the solutes and the water. So it will cause increase in the sodium. The fractional excretion of sodium will be more than 2%. And this is seen in the tubular damage, which is usually a secondary, the primary cause of intrinsic AKI.
Can you please go to the question previous? Yes. So now I think students, you can unmute yourself slowly and we will go to the various questions and we will discuss about the things in detail. Dr. Paul, how many slides you have more?
We've got around 10, 11 slides.
Okay, fine. So approximately 20 to 60% of the hospitalized patients who develop AKI require dialysis. Scoring systems are used to predict the outcomes. So as whichever hospital you are in, there are different ways to, they might be using different criteria. So here we have given the 4 choices: A, B, C, D. A is Apache, B is SOFA score, C is the visual assessment score, and finally D is the KDIGO score. KDIGO score. So can of the students please within 10 seconds, can you say which one of these is a method for using for understanding the GMR, glomerular filtration rate? Please answer. Make an attempt. No, not C. So it is D. So why the answer is C is visual assessment score. Score is I just wanted to elude you all. Visual assessment score is used for measurement of pain. You have the Wong-Baker's phases when you being critical care nurses. Pain is the 5th vital. Yes, D is the correct. Hemalata, you are correct. So D is the correct answer. So what is the KDIGO criteria? That Dr. Paul will concluding the remaining slides. She is going to share with you the idea about the KDIGO criteria. Okay, so please, Dr. Paul.
About AKI classification, there have been numerous classification actually. The Rifle criteria was something initially used. It was around 2004, and then the Akin criteria came into existence. Presently, we all follow the KDIGO criteria. This is actually an amalgamation of the Rifle and the Akin criteria, is almost same as the Akin criteria, as you can see over here. But we have got the time limit also taken in consideration. So when we go to the stage 1, according to the KDIGO criteria, it is when the serum creatinine concentration, it is more than equal to 0.3, and this is within 48 hours. Otherwise, more than 1.5 times in the last 7 days. So this is an easier way of following, and presently for all kind of research work or the other studies, the KDIGO criteria is the one which is usually accepted. This is, I just want to share with you how we should be approaching the oliguria. So by definition, oliguria is less than 0.5 ml per kg per hour in the 2 hours. So it can be pre-renal, renal, and post-renal. That's something we have discussed till now. And how do we go ahead from here? We have talked about the history and the examination. So pre-renal is usually because of fluid loss, or it can be a cardiac cause, it can be sepsis, it can be because of the drugs, or it can also be because of hyperviscosity. So here it is very important to do a hemodynamic assessment for the fluid responsiveness. So we can go for the invasive monitoring if it is available. So we can go for the central line and the arterial line, or we can ask for an echo also. And then after a urine analysis, we can have an idea if the sodium concentration is less than 10 and the fraction excretion of sodium is less than 1, or what is the specific gravity. Suppose it is yes, that means the patient is in fluid deficit. So we can go ahead with the further fluid challenge and hemodynamic reassessment for the fluid responsiveness. Suppose a patient is responsive for this, that means we can continue with the fluid resuscitation. But suppose oliguria persists and despite adequate filling, then we have to think of some other causes. And intra-abdominal hypertension is one such cause. Usually if the pressure is around 22 centimeters of water, then there can be intra-abdominal hypertension, and that should be looked into. The renal causes, we take the history, we do examination of the patient, we do the urinal analysis, and we come to a conclusion that it is the direct kidney involvement. And usually a renal biopsy is something which is advised, but this is seldom we see in ICU. It is done later on. Post-renal causes is obstruction is something we just now went through it. So it can be an ureteric stone, it can be BPH, it can be any other clot which is also causing obstruction. So urine analysis will always show there is crystals, or there can be slough papilla or malignant cells. And for these, we need further investigation as radiological imaging. So it can be an urography and medical MRU, that is magnetic resonance urogram, or retrograde pylography or urodynamic studies. In some of the patient who has got neurological pathology, which involves the bladder, neurogenic bladder, in that patients, we have to think of urodynamic studies. This can also lead to post-renal causes for AKI. So management part of it, obviously, optimizing airway oxygenation and hemodynamic stability is of prime importance. This is the first thing which we see. Suppose a patient has come with pulmonary edema because of cardiac failure, then we should be taking care of the airway and make sure that adequate oxygen is put to the patient. And if the patient still oxygenation is a problem, we can think of securing the airway by intubating and putting him on the ventilator. Hemodynamics is also important, because if the patient has got hypotension, then we have to see if we can give some fluids, and still if it is not possible, then we have to think of vasopressors. Then the next important thing is we are monitoring the urinary output. And if it is less, then we are thinking of the patient will be going towards AKI. So this is the time where we should be able to identify and reverse it, and the patient is not let to go progress towards AKI. Suppose we do a suprapubic percussion, we can understand if there is any obstruction to the bladder. Bladder fullness can be ruled out. This can also be done by a bedside abdominal ultrasonography. In ultrasound, we can also find out if there's any post-viral residual urine. If it is more than 100 ml, then we can diagnose there is a bladder neck obstruction. The volume status can be assessed by checking the diameter and the collapsibility of the IVC, or we can do it by invasive monitoring. Radiological examination of, we try to avoid a contrast CT. So non-contrast CT to diagnose renal hydronephrosis, hydroureter. This is all the complication of increased pressure in the system, the post-renal causes, or to detect the renal calculi. Sometimes pelvic fracture can also lead to the post-renal obstruction, and it can also cause oliguria or AKI. So these kind of patients can require contrast CT that we can always discuss with the nephrologist and the patient or the relatives, and then decide on it. Intravenous urogram retrograde contrast study for the site and the nature of the obstruction. In diabetes, in amyloidosis, multiple myeloma, the kidney size may be normal, even with chronic diseases. This is something we should keep in mind. It's not necessarily the kidney size will be lesser. Any discrepancy in the kidney size, that is unilaterally the size is more compared to the other one, so we can think of unilateral renal artery stenosis. So in these kind of cases, we might have to do a color Doppler to assess if the renal perfusion is adequate or not, or if there is any thrombus. And suppose we are thinking that the patient is in shock, there is a congestive cardiac failure, we should do the adequate management initially and then refer the patient to a cardiologist. Suppose there's an abdominal compartment syndrome, then we should see what is the reason behind it. And if necessary, we should be giving a surgical referral.
So now we come to the next question. It is determined that one of the patient will require kidney replacement therapy. This is especially for the nursing side. This question we have devised for the nursing people. A dual lumen catheter has been placed. You would see, but for dialysis, we need a dual lumen catheter because through one of the lumen, the blood goes into the dialysis machine, and from one, it comes back from the dialysis machine into the patient. During this hospitalization, the patient developed fever with low blood pressure. Cultures were sent from the dialysis catheter, which showed that he developed a vancomycin-resistant enterococci infection. So this is the nurse is now in the contact isolation for VRE, for vancomycin-resistant enterococcus. She has to perform which of the following infection control measures? So I'm basically asking you about a infection control question. First, maintain the standard precautions and contact precautions if the wound and bodily excretions are not contained. Then the second will be, okay, so Sagarika has already answered A. B, arrange for a dedicated blood pressure cuff and stethoscope. C, dialyze the patient at a station with a few adjacent stations as possible. D, perform all the above. So now Sagarika, can you change your question? So A and D. So perform all the above. But what about the C? So dialyze the patient at a station with a few adjacent stations as possible. Is it correct? Okay, let's go to the answer. Dr. Sumona, can you please show us the answer slide? The next slide. So A to C are all part of the D is perform all the above. So Sagrika, you are correct. Perform all the above. A to C are all part of the CDC guidelines for preventing the transmission of infection among hemodialysis patients. Especially this patient requires more. Why? Because this patient is a post-renal transplant, and that is the most important consideration that you have to give. So you have to have special precautions or special considerations when you are dialyzing this patient. Okay, while the same patient has been receiving dialysis in the acute care unit, the staff has been following the CDC guidelines and prevention. These guidelines include A, changing her dialysis catheter and fistula dressing at the same time, wearing gloves when caring for the patient or touching the patient's equipment. C is using a mask and face shield to avoid airborne VRE in contamination. D is performing all the tasks before washing their hands. So what should be the answer? These are all infection control measures. So that is why we are asking. So it is, so Sunita has told D and Sagarika has told A. Include, okay. So no, you want B. Okay. So B is the correct recommendation. Wearing gloves when caring for patients or touching the patient's equipment. This is an important guidelines from the CDC guidelines. The nurse should also remember to sanitize hand after removing the gloves and before moving to the next patient. Can you show the question once more? Because Hemalata is confused about D. Performing all tasks before washing their hands. This is wrong. This is before and after washing their hands. This should have been there. So this was the mistake which we have deliberately kept. So you have to, so that is why B is the only correct answers. Rest all are, there is some incorrectness in all the other questions. So we had made mistakes.
We continue with the management part. we should always keep sepsis in our mind. And whenever we are suspecting sepsis, there should be promptness in starting antibiotics. Urosepsis with oliguria, it requires ureteric catheterization. Here we have to ask the surgeon, urologist to get involved with this, and the patient may require DG stenting or percutaneous nephrostomy. Sometimes there is perinephric collection. The pus of the blood has to be drained. The initial adequate fluid management is very necessary, very important. And we try to keep a MAP almost 65 millimeters of mercury, or if it is a hypertensive patient or the patient who has got IAP, so intraarterial abdominal pressure. So we try to keep the BP on the higher side. So intra-abdominal hypertension, how do you deal with it? We try to give diuretics. If there is an ascites, we go ahead with an ascitic drainage. And then surgical intervention. Suppose a recent surgery has been done and there is a huge abdominal distension. So we try to get the sutures removed. So this releases the pressure. And obviously, there has to be judicious use of diuretics, because here we saw the prerenal majority is because of decrease in the effective blood volume. So in this kind of cases, if we land up using diuretics, it's going to damage the patient and will not help in the management of oliguria.
So we come to the next question. A 44-year-old male is admitted to the medical ICU with a diagnosis of malignant hypertension and kidney failure. A dual lumen catheter is placed for hemodialysis. Serum blood glucose blood values include BUN of 200 milligram per deciliter, creatinine 12.4, potassium is 6.4, and carbon dioxide is 12 milliequivalent per liter. Since the patient has hyperkalemia, the nurse will monitor closely for which of the following: cardiac arrhythmias, non-specific seizures, aspiration pneumonitis, D, respiratory distress. This is a very easy question. So Sarika has already answered it. So it is cardiac arrhythmias. That's fine. So can somebody say what is the type of arrhythmia that you commonly expect in hyperkalemia patients? Yeah, Hemalata, it is correct. You have told A is correct, but what is the arrhythmia that you normally find in patients? Can somebody answer it? Okay, we will discuss at the end of the session. Dr. Sumona, please. Hyperkalemia can cause, this is what is mentioned here, can cause progressive electrocardiographic upheaval. Peaked tall T waves is very common in the ICU. So whenever you are seeing your ECG, you have to see the tall T waves. You have to always be cautious about the flattening or absence of the P waves and widening of the QRS complex. So these P waves, flattening or absence is very difficult to see in the monitor because they are very small changes. But the widening of the QRS, once the QRS is widening, it's a fatal thing. And if you do not dialyze, even with dialysis, these kind of patients may or may not make it. So T waves is probably the only thing which we can actually do it in our ICU, and this can actually help us in diagnosing it early. And we have to be very vigilant. You have to understand what kind of a tall T waves are there when hyperkalemia is there. Okay.
So we were talking of metabolic abnormalities, and we get a metabolic correction, what to be done. So we have to do frequent monitoring of the electrolytes and correct the metabolic derangement. So in any patient who has got oliguria, obviously the potassium is not getting excreted. There will be hyperkalemia. There will be hyper or hyponatremia. There can be hypocalcemia. Phosphorus, it's very common to have hyperphosphatemia, but hypophosphatemia can also be seen. In this kind of patient, to avoid calcium overload, we should try not giving antacid containing calcium. And here is the thing with high urea creatinine ratio. Now, this indicates there is volume depletion. So it can be because of acute GI bleed or a high protein feed. So this kind of patient can be identified and we are able to replace the volume. Rhabdomyolysis when suspected. So if there's any suspected trauma or injury where we are suspecting the oliguria may be because of rhabdomyolysis, we try to maintain a urinary pH more than 7. And this is by systemic alkalinization, that is by giving soda bicarb. The exposure to the nephrotoxin drugs should be always be evaluated. And suppose it is there and we are able to identify, especially with the history of radio contrast administration, we should try to, in high risk patient, we try to hydrate with 0.9% saline. N-acetylcysteine actually doesn't have much proof, but we can always administer around 600 milligram twice a day, 3 days prior, because it doesn't have much of side effect. Preferably, you try to use an isoosmolar contrast, avoid nephrotoxic drugs, antibiotics like aminoglycoside. We try to go for a once a day dose. We go for the lipid formulation of amphotericin B. IV voriconazole can be avoided because it contains the beta cyclodextrin, which is again toxic. Chemotherapeutic drugs also has got a history over any patient having a history over the counter drugs. Many of these are nephrotoxic, and usually they don't tell about it if we don't ask for it. Exposure to ethylene glycol or methanol, these all can lead to injury to the kidney, the tubules. Avoid NSAIDs. There's no role of renal dose of dopamine to increase the renal perfusion. This is something I think you all are aware of it. Just to rectify. Early AKI detection, many criteria is there, but presently we try to follow the KDIGO criteria. And the first stage is actually when there is the serum creatinine is 1.5 times or it is 0.3 milligram per DL, and or there is fall in urine output. Biomarkers, you must have heard of it. There are certain biomarkers which are used, like the NGAL, the interleukin 18, the TIMP2, that is the tissue inhibitor, metalloproteases 2. Now, these can be used to identify the AKI quite early, almost 24 hours to 12 hours before the actually injury setting in. There's another thing we can always try it out, the furosemide challenge test. Now, after a reasonable correction of the volume status by administration of almost 1 to 1.5 milligram of kg of furosemide bolus, may help in identifying AKI. The urine output is usually less than 200 ml in the 2 hours of the diuretic challenge, is indicated that we might have to think of renal replacement therapy. Now, this is almost 80% sensitive and specific for RRT initiation. So if you talk of RRT, that is a renal replacement therapy, a patient who's having oliguria goes into anuria, and here we are diagnosing AKI. Do this patient require renal replacement therapy or not? It's a very simple mnemonic, AEIOU. So if there is any acid-base abnormality, pH is less than 7.2, electrolyte imbalance, if hyperkalemia, hypermagnesemia, usually the potassium, it is almost 7. Intoxication, if there's history of any kind of toxin being given to the patient, like ethylene glycol, salicylate, phenobarbital, theophylline, we can go ahead with dialysis. Fluid overload, patient has got pulmonary edema, or there is a patient is unresponsive to diuretics, then we can think of renal replacement therapy. And uremia with this complication, like the patient has got neuropathic neuropathy or uremic encephalopathy or pericarditis. In this kind of patient, we have to think of renal replacement therapy. For monitoring of the patient for a better outcome, this is something which you can be vigilant for. Every shift, you can see how much of the patient is getting an input and output. Is it well maintained or not? And some patient who is on dialysis, we can think of weighing the patient. Hemodynamics, are they all well preserved? This should be done every shift. I'm sure you do it. The blood chemistries, these are to be done daily, including blood glucose. Serum concentration of data for drugs, like after renal replacement, we should be trying to see if the concentration of the drugs has come down or not. Then the administration of the drug doses. And that also we should be careful, because after renal replacement, you should be given an extra dose. Then they calculate the creatinine clearance or the fractional excretion of the sodium. Now, these can be done every time whenever urine collection is performed. There's another important thing. This is the nutritional consideration in the renal injury. Suppose the patient is stressed, inflamed, or there is kind of injury, which is all a hypermetabolic or a hypercatabolic state. For these kind of patients, they require extra nutritional requirement. And many of the patient who has got renal injury will be severely malnutrition. So 42% of the AKI patient are malnutrition, having malnutrition. So according to KIDICO guidelines, calorie intake should be 20 to 30 kilocalories per day. That is the enteral feed. And protein should be 0.8 to 1 gram per kg per day. But suppose a patient is receiving RRT, it increases to 1 to 1.5 grams kg per day. So in conclusion, there has to be a systematic approach to oliguria in all the critically ill patient. And we try to analyze the multifactorial etiology of the problem and try to make sure that the patient doesn't deteriorate to anuria and leading to renal replacement therapy. Timely diagnosis and prompt intervention may decrease morbidity mortality from this potentially preventable problem. Mortality rate in patients with AKI in ICU is in excess of 50%. So this is a very high number. We should be aware of it and take all kind of a care that a patient who's having oliguria doesn't lead into AKI. Thank you very much.
Thank you, Dr. Paul. So now we can start our discussion. So Dr. Paul, can you show the first slide, the case report, which was the first one?
Okay, I'll just go back.
Okay. So here, I think for the students, there is a lot of, you must have been, when we initially started with this, there was a lot of jumble about why such a big question has been with so much of blue marks in everywhere. So this question was basically formulated to, it is a kind of a jigsaw puzzle for you all to understand that when you are looking at a case of oliguria, your eyes and ears should be open to the history and what is happening to the patient. So first of all, let us see the first line, the 45-year-old hypertensive. So we type this in hypertensive because hypertensive patients, whenever they are in your ICU for any reason, when they are admitted under you as a critical care, it is your duty to, when you are writing your nursing notes, nursing handover, when you are giving a handover, you should always mention that this is a hypertensive, diabetic, or whatever is the history, chronic history of the patient. Why? Because the patient who is hypertensive or who is having diabetes, mellitus, or who is having some chronic disease has a more chances than the others. Any other patient who is in your ICU without these pre-diseases conditions have more chances of going in for oliguria or AKI, acute kidney injury. So that is why this 45-year-old hypertensive was highlighted. So this was mainly to show you that this patient is more likely to have a kind of oliguria in the ICU. Next, we come to, he has been on ARB blockers. So now we, madam, during had one slide on the angiotensin receptors and what was their action. So these people, when they are having ARBs, so they are more prone for hypotension, especially in the ICUs. So what happens is these people, we have a more chances of having pre-renal hypotension and pre-renal cause of oliguria. So then he was taken up for reduction of internal fixation. As you all know, that post-orthopedic surgeries, we give the patient, if they are not given DVT prophylaxis proper, or even with some, because of the immobilization, they may have pulmonary embolism. So what is the cause of pulmonary embolism? Can somebody say in the chat box? You can unmute yourself also. You can also discuss. So if somebody wants to answer, they can unmute and they can say. So this massive pulmonary embolism, which is mentioned here, what kind of a AKI or oliguria, which will, because after this requiring thrombolysis, he started becoming oliguric. So what is the type of oliguria which we see in massive pulmonary embolism? Can somebody say? It is a pre-renal. So because it has happened from the before the kidney. So it is a direct decrease in the flow, blood flow. So it is pre-renal. Then next we come, he started become oliguric. He was also having hypotension. So hypotension is again another pre-renal cause of AKI. So on investigation, it was discovered that he had developed retroperitoneal hemorrhage. Now, can somebody say what is the significance of this retroperitoneal hemorrhage to oliguria? Can somebody type or directly unmute and say? Retroperitoneal hemorrhage causes an increase in the intra-abdominal pressure, and directly it can cause a pre-renal kind of a renal failure in these patients. So in this one particular question, we tried to signify and we tried to ask you or highlight 5 different types of causes of pre-renal oliguria. So this is the hypertension. This is a predisposing cause. ARV, use of ARB blockers. Then third is having a massive pulmonary embolism post-op and going into prolonged period of hypotension. And finally, retroperitoneal hemorrhage leading to increase in intra-abdominal pressure. So these were basically the 5 different aspects which we were there. So now I would like to tell to all the nursing, because since this is predominantly a nursing, so NABH also, those who are working in, I think most of you will be working in NABH or JCI accredited. NABH gives a lot of credence to the charting of the daily output of the entire patient's vitals and the patient's findings. It is mentioned there. So why do we give that? So you can now understand that from the definition of oliguria. So it is only a 2-hour phenomenon that you are having a patient. You can say a patient is going into oliguria. So it is this 2 hour where you are the main bridge between the patient, his outcomes, and the doctor, his response. So if you fail to either give a handover, let us say this particular 2 hours of oliguria has happened during a phase in your nursing care, which is almost, let us say, in towards the end of your shift and the beginning of your other shift or the previous person, and it is during this period that you have missed the recording or you have not given a proper handover to the next person. So this oliguria may go to further, may cause damage. Remember one thing, indicators like serum creatinine are not absolutely indicators of renal damage. They detect damage to the kidney only when more than 50 to 70% of the nephrons are already damaged. So it is not that after you have a raised creatinine, we are going to take care for the renal part. It is something like there is no point in using that. It is, of course, we do take care to correct those things, but it is quite late. So we can actually intervene before with a very vigilant nursing where we can identify the oliguria at a much before stage. We can actually help the patient much more and prevent this acute kidney injury from developing further. So an important part of your nursing care will be that you have to have a proper charting, noting, and giving a proper handover about the urine. So any other questions? So if there are no more questions, then I think we can end this session. Thank you, everybody. It was nice interacting with you all. And thank you to the students also who made a lot of answers, and most of them were correct. So thank you, everybody.
Thank you very much.